It was nice meeting. I'm going to turn my screen off so that I'll fade into the background.
Okay, so welcome everyone. As you all can clearly tell, Rachel is not here today, and neither is Julie. So I'm going to be covering today's seminar. Because Rachel is out on vacation, I just want to kind of send a request for some patience with us. So we do normally send out the slides. We try to do it a week in advance, but because Rachel's not here, please just give us a little bit of extra time. When she gets back, she's going to be working on last week's seminar and then this week's seminar as well. So if you have questions, definitely feel free to email her, Julie, or myself, but just know that we're going to be taking a little longer to get back to folks. So just please be patient. So having kind of got that off the table, I want to go ahead and get started. So welcome to the University of New Mexico Law and Mental Health Didactic Series. So this series is hosted by UNM Department of Psychiatry and Behavioral Sciences and the New Mexico Behavioral Health Division. We are so glad to have you all here today. My name is Vivienne. I'm an assistant clinical professor in the Department of Psychiatry and Behavioral Sciences. Before we get to today's presenter and also next week's presentation announcement, I want to let everybody know that we are accepting applicants for the Forensic Postdoctoral Fellowship. We have 2 spots available for the 21-22 year. Our brochure is ready to go. We also have a website through UNM. So if anybody is interested, please definitely contact us. Our applications are due on January 14th. And so that's just a couple of short weeks away. And I also want to let everybody know that we just got approved for the 5-year waiver, which we are incredibly excited about. So that's something that just recently, we just recently got that a couple weeks ago. Okay, so like I said before, you can email myself or Julie if you would like a copy of the brochure. Next, I want to let you know that we would love for you to join us next week, where we're going to have Chris Slowbogen, who will be presenting on the ultimate issue. So that should be really great. Definitely make sure that you join us next week for that. Okay, so for our talk today, we normally do questions Q&A at the end, but Vivienne has let me know that she's got some distinct blocks in the presentation. And so what we're going to actually do is save questions for the end of each block and take some time to go over some of the questions, but also know that we might have to just sort of get going to the presentation and save most of the questions for the end, because we want to make sure that Dr. Vogel can get through her entire presentation. So please forgive us if we don't get to your question. We do the best we can to try to get to everyone's questions, but sometimes we just don't get through everybody. So again, your patience is really greatly appreciated. If you need the CEUs, you have to stay for the full hour. We will be going over a couple extra minutes. Dr. Vogel has been kind enough to agree to stay on for some questions afterwards. So, but if you are tight on time and you need to go, that's fine. I will put an announcement out. I'll kind of jump in and just let everybody know that the hour is up and that the CEU link will be posted, and we will, and then you're welcome to jump off and we'll continue on with questions. Okay, so with, I think, all of that housekeeping out of the way, I would love to introduce our speaker today, Dr. Vivienne de Vogel. She is a PhD, has a PhD and is a professor at the University of Applied Sciences in Utrecht Research Center for Social Innovation. Furthermore, she works at the research department of the Forensische Zorgspecialisten. It's been a long time since I spoke Dutch, so excuse me for butchering that. So it's a Dutch forensic psychiatric center. Her research interests includes forensic care, gender issues, violence risk assessment and management, psychopathy, victimization, and working alliance. I've also had the wonderful pleasure of working on some projects with her. She's a wonderful human being, and I'm really grateful that you took the time to present at our seminar today. So thank you for taking the time. On behalf of UNM, Department of Psychiatry and Behavioral Sciences, we would like to welcome you, and we enjoy having you here today. So thank you, and I'm going to go black and leave it up to you.
Okay, thank you. Thank you very much for this very nice introduction. And I'm also very happy that you invited me. And thank you all for participating. And I just told Simone in the Netherlands, I think everybody's on vacation, but you are all still working. So that's great to have you joining this session. I will start sharing my screen now, and then I will go over. Oh, sorry, this is the disclaimer. I'm not sure. I will start over again because it don't seems to be working. Yes. So oh, it's again the disclaimer. I'm sorry. I think something's going wrong here. I don't know if you can see it, Simone.
So I see the slides. Do you want me to try to just share my screen? Because I see the screen, and then when
yeah, there's someone still open. It looks like.
Oh, everyone, we tested it and it worked perfectly before, of course. Would you like me to open your slides and share for you? Should we try that?
Yes. Yes.
Okay, let me do that. Oh, let me pull up your slides really quick. And that's opening.
Maybe I try again. Can you see it now? I think it's working now. Yes.
Good. Okay, I do have it open in case.
I think I had it open twice. So sorry about these couple of minutes of delay. So what I'm going to talk to you today about is about violent women, gender issues in forensic mental health care. And Simone just introduced me, but I would also like to introduce a little bit further. I work as a professor at the University of Applied Sciences in Utrecht, and I also work at the research department of the Forensische Zorgspecialisten. That is the Dutch word, and it means the forensic care specialists. It's a forensic psychiatric center in the Netherlands. The Vogel Clinic is one of the hospitals, and I've been working there for over 20 years now. And in this hospital, we admit both men and women. And ever since I started to work there, I've been wondering what we do with these women in these forensic psychiatric centers, because they're obviously a minority of the population. And all the methods, assessment tools, etc., we use are actually developed and validated in male population. So my curiosity is about these women and how can we improve assessment procedures and treatment for them. So that's mainly the basic of my work. And I also work as a scientific advisor for a committee, an independent committee who does observations for proposal leaves. So I have to show you some general slides that go along with this presentation, a disclosure and a disclaimer. And I also want to show you some learning objectives for today. And this is also basically what I'm going to talk about. So I hope that you will all learn from this presentation more about the background of female offenders. What are the most important background variables, like their trauma history, psychopathology, are there differences in violent offending, etc. And I also want to show you something about a risk assessment tool, that is the female additional manual. And this tool can be used in addition to standard risk assessment tools like THCR20. And finally, I want you to learn something about gender responsive treatments and also to be able to recognize challenges and pitfalls in the treatment of women. And like Simone told you, I have 4 blocks in my presentation. And if you have any questions, please put them in the chat and I will hear them from Simone. The first block is some general introduction about violent and antisocial behavior in women. And then I will go over to some research results we did in the Netherlands to investigate more the background of these women who are admitted to forensic mental health care. something about the risk assessment and risk management, and I will end with a case study. And this is a case Kelly. She has been admitted to our forensic psychiatric hospital. And just to illustrate some issues that are going on with the risk assessment and management in this case. So I often start my presentation with this newspaper headline from a couple of years ago, and it was a newspaper about a research that's found that hurricanes with female names are deadlier. So actually it wasn't a very sophisticated empirical study, but still I think it's a good metaphor, because we still tend to underestimate violence by females. And the explanation of the researchers of this study said that, well, if there's a hurricane with a female name, people are less scared, they tend not to evacuate. While there is a hurricane with a male name, they are obviously more scared and they tend to evacuate. So that is an explanation. And I think it's really a nice metaphor to show that in society, in general, we still believe or think that women are caring and are sweet, and they are not violent or antisocial. And if they do act violently or antisocial, it's because they were forced by a man, or they were a victim, or they're really severely mentally disordered. And these sort of, well, explanations are less provided for male offenders. And we also see this in the way the criminal justice system responds to female offenders. Overall, we see a tendency to treat female offenders more leniently. They get lower sentences, and they are also more often seen as not fully responsible for their behavior. So why do I feel it's important to gain more knowledge about these female offenders? And actually, with my colleague Tanya Nichols, I was editor of a special issue of the International Journal of Forensic Mental Health in 2016, and there we summed up the reasons for more knowledge into this group. What we see, and actually we see this worldwide, is a rising numbers of female entering the forensic mental health system and also in the prison system. There are several explanations for that, and sometimes it's debated whether it's an actual rise in numbers or it's more visible. But still, we do see a rising number of females entering the system. What we also know from research is there's an intergenerational transfer. There's a large body of research that has found that these children of these women who are violent or antisocial have a very high risk of multiple problems in their development, criminal facts, but also mental health issues, substance abuse, risk-taking behavior, etc. And obviously this is also the case when fathers are violent or antisocial, but the effect seems to be even stronger with women, probably because mothers spend more time with their children in general. The third reason why we thought it is important to gain more knowledge is also for the recognition of victims of female offenders. Most of the studies have focused on female victims of male perpetrators, but there's also obviously the other way around. And what we know of these studies is that it really doesn't matter if the perpetrator was a woman or a man, because the consequences like depression or feelings of anxiety have been reported the same. And some studies, there are some qualitative studies that even found that victims reported to be worse that it was a female perpetrator because they didn't expect it from a woman. So it led to a deeper sense of betrayal. So what I'm going to tell you about today is mainly about a study that we conducted in the Netherlands. And as I told you, I work at the Forensic Psychiatric Hospital, admitting both men and women. And I was really curious about these women, but still in our hospital, it's also a minority. So I had to collaborate with other facilities in the Netherlands. And we did a joint collaboration project into these gender differences. Overall, we had nearly 300 cases we studied. And we also matched these cases to male patients. And we matched them on the year of birth, year of admittance, and a judicial status. And what we did was we coded the files of these patients with several tools like risk assessment tools, the HCR20. I hope you're all familiar with it. It's a standardly used risk assessment tool in the Netherlands and also worldwide, very widely used. We also applied the START, the SAPROF, and the psychopathy checklist. So the major aims of our study were to gain more insight into the background of these women, their criminal characteristics, their psychiatric characteristics, and especially what are the most important risk factors or protective factors for these women. And obviously with the goal of improving treatment and improving risk management to gain more insight and to have possible implications for that. So today I'm only going to give you a brief summary of this project. It's an ongoing project since 2012. So we did a lot of sub-studies, for instance, into gender differences in offending, but also into victimization, several mental disorders like borderline personality disorder, psychopathy. And if you're more interested in detailed knowledge, you can also mail me, or you can look at my ResearchGate profile where you can find most of these articles. So today I'm just going to give you a brief summary of it. So first, some general characteristics. It's not really exciting, but well, the mean age upon admission was almost 36 years. Most of the patients were born in the Netherlands. And then what I found interesting is that at the time of the index offense, so that is the offense for which they were admitted to forensic mental health care, almost half of them had an intimate relationship and children. But with respect to these children, they were hardly capable of taking care of these children, because most of these children were not living with their mother any longer. They lived with family or in foster homes. And when we looked at one of the items of the female additional manual, it's called parenting difficulties. Almost all of these women got a high score on that risk factor. So these women were not able to take care of their children, with potentially devastating consequences for these children. Then we looked at the criminal characteristics of these patients, and we found that the majority of them had had previous contact with law enforcement, part of them without actual conviction. So they were arrested, but because of mental disabilities, they were set free, or they called the police themselves frequently. So not all of them were convicted, but the mean age at first conviction was 25 years, and this was somewhat higher than for the males. The average age of first conviction of the males was about 20 years. Mean number of previous convictions was 4, mostly concerned violent or property offenses. So then we go over to the offenses for which they were admitted to forensic mental health care. And what you see here, these bars, and it's actually a bit stereotypical, but the pink bars are for the female cases and the blue ones for the male cases. And what we see here is that actually the offenses, the seriousness of offenses was also very high for the women, because homicide was very prevalent in the female population, even higher than in the male population. You see that at the left bar. Another difference was that arson, almost a third of the female patients in the forensic mental health care had been convicted because of arson. And then another difference is that sexual offenses were mainly committed by the males, as well as violent, and that is other violent offenses than homicide. So there are some important differences here. And one of the explanation possibly for the higher prevalence of homicide and attempted homicide is when you look at the victims of these offenses. And what you see here is actually that children are more often victim of the female patients compared to the male. So we had a reasonably high number of women who killed their own child or possibly children of someone else. And another difference we saw is that stranger victims, so the man on the street, that's more often with male offenders. So usually the victims of female offenders can be found in their direct surroundings. Next, we also try to capture the motives for offending. And obviously this is very difficult because it's not easy to pinpointing motives, or we were not able to ask the patients themselves, but we try to code it from the police files. And what we actually saw, what happened a lot in the female cases, was the cry for help. And you often see this with women who commit arson, but also more relational motives like revenge or jealousy, or maybe threatened loss. And motives like power, dominance, that we saw that more often in the male offenders. So there was actually a difference between relational motives and more antisocial motives. Are there any questions?
Okay, looks like we have one question, or two actually. So did many of your female violent offenders, especially those who killed or attempted to kill their children, suffer from postpartum psychosis?
Well, postpartum psychosis, I think it was only in one case really diagnosed, which doesn't mean that it wasn't there. I think that women who kill their children in a postpartum psychosis will end up in general psychiatry in the Netherlands. So usually when they end up in forensic mental health care, there's also some antisocial behavior and some other problems in the cases.
Then we have one more question. What about self-defense as a motive?
Self-defense, yeah, there's a lot of literature about that, also about the motive of self-defense. In the population that we studied, I can't remember one of only self-defense. Usually they said it was self-defense because they were in a very violent relationship with domestic violence. But when you look more closer into detail into the history of the relation, there has been violence from both sides and also some other problems. So only self-defense as a motive, we didn't get that, no.
And then the next question is, were the coders blind to the subject's gender? For example, jealousy versus dominance.
No, that was not possible because we went to the hospitals where these files were, and we studied the complete files of these patients. So we knew the cases, and at the same time we coded the motives. So we were aware of the gender. Yeah. So it's not a really, if you really want to do it well, we actually adopted a system from Jeremy Coit in coding motives. You have to do it all over again with this coding system. We adapted the coding system and use it now merely as a descriptive study. But if you want to properly study it, you have to do it blind to gender. That's a good question, actually. Yeah.
The next question says, how about parricides?
No, I don't think there were many. No, not that I can remember. No.
Okay, the next question says, regarding how the media portrays female offenders, perhaps the inaugural text on the subject, real knockouts, violent women in the movies, edited by Martha McConaughey and Neil King, touched on the issue of films and women in prisons. The question is there any rapprochement or nexus between immured women and TV and cinema representations / reflections?
Oh, that's a difficult question. I'm not sure if I really understand the question. Is the question that it has an impact on violent offending?
Yeah, so maybe that person, if you want to type a follow-up question to be more clear. And then I'll move on to the next one for now, and then if maybe that person can clarify the question. The next question says, Sandra Bem conducted a study of women in psychiatric facilities and found those women failed to develop psychological traits of femininity or masculinity, androgyny. What are your thoughts on that? That they
Sorry,
fail to
about?
develop psychological traits of femininity or masculinity.
Oh, I'm sorry. I'm not sure if I understand the question correctly. No.
I guess they're wondering if in your research you've considered like feminine traits, masculine traits, if that's somehow related to their offending behavior or.
Oh, in that way. No. We didn't investigate that. I think that's difficult to really point it out, these traits. So no, we didn't do that. Sorry. No.
The next question is, would women use PCL-SV or PCL-R? With such low base rates of psychopathy in women, do risks outweigh benefits of using these instruments?
Well, I'll get back to that later when I talk about risk assessment, and I go also over to the PCLR. Yes.
The next question is actually about the sample and how internationally representative you think your sample is.
Yeah, that's a really good question, because it is a Dutch sample, so I'm not sure how representative it is. I see there are also differences in the way countries in how they treat forensic mental health care. And in the Netherlands, people have to be considered diminished responsible for their offense to be able to get to the forensic mental health care. And the offenses have to be severe. So that means mostly violent or sexual violent offenses for which at least 4 years of imprisonment is scheduled. So it's a kind of a typical population, but still, when I talk to colleagues from other countries, I think the problems, the background problems are, I think, well, comparable also to the literature. Yeah.
Okay, so I think we're going to move on. So
shall I move on? Yeah. Okay, so if you have more questions, I will be able to stay afterwards to answer some of the questions. So that was the part actually about the offending. And next we dived into the background of these female offenders. And first, in the literature, we see some important differences, gender differences. And I think these are the most important ones: a higher prevalence of trauma, especially sexual trauma, more complex psychopathology, more internalizing behavior, and a longer treatment history. So this is actually what we found in the literature. And now I'm going to show you what we found in our study. So first, we looked at the victimization during childhood. And what you see here is actually there was not a big differences between men and women in emotional trauma or in physical abuse. It's actually about the same, but we found the strong differences in sexual trauma. Still, I have to emphasize that about a quarter of our male forensic mental health patients also suffered from sexual victimization. So that's really a substantial part, and we should not forget about that, because it's really important that they are being treated for that as well. But in the female sample, we see that more than half of them had experienced sexual abuse, so twice as high. And we also noticed that all three types of victimization happened more often in female patients. So that's the most important difference. And in another study, we also looked at, we did a relation between the trauma and psychopathology, and we found a relationship between physical abuse and the development of antisocial personality disorder in male patients. And for the female patients, we found a relationship between sexual abuse and the development of borderline personality disorder. So there seems to be some sort of gender-specific roots, you can say, and women tend to more to internalize problems and men to externalize problems. So this is the victimization during childhood. Then we looked at victimization during adulthood, and there we saw more differences between the genders. And what we actually saw was that while the men more often became perpetrated themselves, the victimization continued for the women. So there were more enduring patterns of victimization, you can say, for the female patients. Obviously, there may also be a bias in this because probably it's not often reported when a man gets victimized during adulthood, or he doesn't perceive it as victimization. So there may also be various biases in this, but this is what we actually saw in the files as being reported. Then next we looked at the psychopathology, and we have the DSM diagnosis for that. And we actually found very high rates of comorbidity. So multiple disorders that were present, also a high rate of substance abuse problems. And in the female population, we saw a high prevalence rate of borderline personality disorder was the most prevalent personality disorder. And narcissistic was the least prevalent. So to put it in a figure, we get this. Borderline more often in female patients, and antisocial and narcissistic more often in the male patients. And obviously here there may also be a gender bias, because impulsivity is often labeled as borderline trait for the women, whereas in men it's probably labeled more as an antisocial feature. So there may be some biases here as well. Next, we also looked at their treatment history. And what we saw, it's actually kind of sad, because most of these women, and also men, but especially the women, had been in treatment before. So more than a third had been in treatment before the age of 17, so during their childhood. And later on, almost all of them had been in treatment after that, so 88%. What we also saw was a high dropout rate. So 3/4 of these women had been in treatment, but they dropped out due to various reasons, suicide attempts, violent incidents, not being motivated, etc. So I think this is important to also share this knowledge, and this is what we try to do in the Netherlands with the general psychiatry, to collaborate more, and possibly we can prevent women from becoming serious offenders, we hope. Any questions? This was my second block. I see I go rather quickly. Are there any questions?
There are some questions, but I think folks are a little worried that they're not going to be able to hear you. So let's, I think, go back to just questions at the end, if that's okay with you.
Yeah. Okay, then I will go on. Okay, so I hope this was all clear. And now I'm going to talk about the violence risk assessment, because what does this all mean for the violence risk assessment we conduct in these patients? I'm not sure how it works in your country, but in the Netherlands, the risk assessment has become a very important topic in forensic mental health care. And it's really depends on the risk assessment if someone can go to another phase in treatment or can be discharged. We have to do risk assessment at least once a year for all our patients, and that's mandatory. We use the HCR20 version 3, or we can use a Dutch tool. We also use the psychopathy checklist. And now I'm going to talk about what we do with the female patients. So what we know from the literature is that there are some significant differences in risk factors for men and women. What we also know from some previous studies is that in general, and that's maybe just like the metaphor I showed at the beginning, is that mental health professionals, both men and women, tend to underestimate the risk of violence in women. So that's apparently still a bias we also have as mental health professionals. In the Netherlands, we have an ongoing discussion right now about domestic violence, especially now during the corona pandemic. And all of the newspaper headlines and all of the programs, education and preventing programs are focused on male perpetrators and female victims, while what we actually see when you look closer to the cases is that it's more reversed violence, and there are certainly female perpetrators as well, but we don't seem to recognize them. And that's both because we underestimate the risk of violence in women, but we also tend not to see the victimization in men. That's also a sort of a bias. So what we also know is that most of the tools, almost all of the tools that we use, at least in the Netherlands, but also worldwide, have been developed in male populations and mostly studied in male populations and validated in male populations. And also when you look closely to the item descriptions, some tend to focus really on male antisocial behavior. For example, when you look at the psychopathy checklist, which is not a risk assessment tool, but still used in this way, is the first item, superficial glibness. It's actually literally stated as he conducts as a macho man. So how to code this for females? That's really difficult. So we also found in the literature some questionable predictive validity for the tools for women. It has been a bit mixed, the results, at least when we started to develop the female additional manual, it was questionable. So considering these ambiguous research results and also considering a need from daily practice is what we saw in our own hospital, the growing population of females, but also wish for more guidelines by mental health professionals for better risk management and more gender-informed treatment. At the other side, we also noticed that there is also considerable overlap in risk factors. It's not like it's completely different picture for men and women. So there is an overlap. Most of the risk factors seem to be valid for both men and women. But maybe they should be interpreted a little bit differently, or we are missing some of the risk factors. So what we did, and actually we did this over 10 years ago when we developed the female additional manual. It was still at the time of the HR20 version 2, version 2, not version 3. We decided to have some additional guidelines to the HR20 and now to the HR20 version 2. And what this means is that we have some additional guidelines to some of the historical risk factors, but mainly we have some new gender-specific risk factors that emerge from the literature and also from clinical experience. And we added 3 extra final risk judgments. So we do not only look at the risk of violence to others, but also at self-destructive behavior, the risk of victimization, and the risk of non-violent criminal behavior. And we mainly developed the female additional manual also as a research tool. So to study more, because it's still, there's not much research, it's still a minority. So it takes really time to really validate these sort of tools in female populations. So these are the gender-specific items that are in the female additional manual: prostitution, parenting difficulties, pregnancy at a young age, and suicide, of suicidal behavior and self-harm. There seems to be a strong link between violence towards self and violence towards others, also for men, but especially for women. So these are some extra historical items. We also have some additional dynamic risk factors. For the clinical items, we have added covered manipulative behavior. And this is actually what was reported by mental health professionals. What they see in clinical daily practice is that with the men, it's more what you see is what you get. And for the women, it's more subtle, more covered, like gossiping or manipulating their environment. Another factor, and it's actually an interesting one, is low self-esteem. In the literature, it hasn't been proven that low self-esteem is a risk factor for violence, but for women, this may be different because it's strongly related, especially to violence towards children, or well, yes, children who are not able to stand up for themselves. So it's like a feeling of hopelessness and stress that may cause them to become violent. And then we added 2 additional risk management items, that is problematic childcare responsibility and problematic intimate relationship. And this is actually what we see in our patients, that they tend to go over and over again in problematic intimate relationships. So relationship problems is also one of the historical items in the HR20, but we emphasized it to also be a dynamic risk factor. So we developed a female additional manual in about 10 years ago. And all this time I had to try to validate the tool, and this was extremely difficult. And I also tried it in this big study I just talked to you about. So in the study with almost 300 cases, we also did a follow-up study. And this has been published a year ago. But we only had 78 women who had been discharged with a follow-up period of at least 3 years, because that is needed before you can capture the recidivism rates. So it was only a small group of women who actually went back to society. They had a mean follow-up period of 12 years. And what we found was that a substantial part of them were admitted again to a psychiatric setting after their discharge. Some of them we were not able to retrieve their recidivism data. But what we also found, and I found it to be a bit shocking, is that 14 of these women had already deceased. So they passed away at a mean age of 44, is actually quite young. And well, we've been thinking what could be the reasons for that, what could be the explanation for these early deaths. We were not able to retrieve the causes of death, but what we think that's, oh, sorry, I thought I had another slide. What we think that it may be caused by, well, we know some of the cases died by suicide, that we know that from our own hospital, the women who died, but also like self-harming behavior, trauma, substance use, the combination of all these problems are making these women very vulnerable, also physically, and well, apparently it's a high risk for mortality. So when we looked at the recidivism rates, we were able to retrieve recidivism dates of 71 of these women. And we found that about a third of them had a new conviction for an offense, and 18% had a violent offense. And these recidivists, they had a mean number of reconviction of 5.5. So it was just not one incident, but some of them had multiple, one even 18 new convictions. And we found that these recidivists had significantly higher scores on all of the risk assessment tools that we had administered. And then obviously the predictive validity of the risk assessment tools, we were especially interested in that. And what we found we both looked at the 3-year follow-up period, but also at the total follow-up period of 12 years. And we found moderate to good predictive validity for general recidivism for most of the tools that we applied. So not really excellent, but moderate to good. But we were mainly interested, obviously, in violent recidivism. And then it was a bit disappointing because none of the tools demonstrated significant predictive validity. We only found significant predictive validity for the dynamic, the clinical items of the HR20 version 3, and for the start vulnerability scores. So that's actually quite notable because these are dynamic risk factors, and they were mainly predictive for the longer term. So for the 12-year follow-up periods. So apparently these dynamic risk factors that can change rapidly still predict on a longer term in this female population. And in male populations, we see it usually that the historical items are the best predictors. So there's something different in this female sample. And it may be that for the male patients, the antisocial side is more important. And for the female patients, the psychiatric characteristics are apparently more predictive and important. Another thing was that we found that the final risk judgment, so not just adding up of all the risk factors, but the final risk judgment of low, moderate, or high, they shown good predictive validity, better than the score. So this is also what we found in our male population, but for the females as well. And we found that the HR20 version 3 It was not significantly better, but we saw rather strong improvement compared to the HCR20. So actually, this is also what I think from clinical experience, that the HCR20 version 3 is better able to capture the risk factors in a more sophisticated and refined way compared to the HCR20. So it seems that the HCR20 is for female patients a much better option than the old HCR20. And unfortunately, and this is what we were interested in, of course, we found no incremental validity for the female additional manual. The FAM did pretty good, not very good, but in a moderate range, but it did not add value to the HCR20 version 3. So the question obviously is it then no longer needed with the version 3 for better prediction of physical violence? When your goal is to predict violence, you can answer that no, the FAM is no longer needed. However, there may be a clinical value in applying the female additional manual because it makes you aware of more gender issues, of possible more gender sensitive risk management, or options for better gender informed treatment. And it may also be predictive of the other outcomes, which we could not retrieve in this study. I hope to do that in a later study, for the prediction of self-destructive behavior, for instance, or the prediction of victimization of non-violent criminal behavior. What I can recommend, however, is that the method of the structured professional judgment, so the final risk judgment, the considering the risk factors, not just adding them, but really thinking about them, combining them, etc., seems to be working pretty well. We already found that for the men, but I think that can be used as well for the women. So that's a bit of reassuring to me and to our female patients that what we are doing in the Netherlands with the HCR20 version 3 works pretty well. It's not completely useless in female patients. Okay, take a look at the clock. I still have 15 minutes, so maybe there's some time for questions before I go over to the case study.
Sure, we'll do a couple questions to make sure we have time for the case study. So just some general questions about the sample. Did you have any developmental disabilities or TBIs in the population?
Yes, we had some developmental disabilities, and I'm not sure the number, but pretty high mental disabilities. And it was actually a more vulnerable group, I think, in the Netherlands, because the victimization rates were pretty high because they were so vulnerable because of these disabilities. But no, I cannot say the number. I have to look it up.
And then somewhat affiliated question, were there any transgender or gender non-conforming individuals in your sample?
Yeah, that's really an interesting question because we're struggling with that in our hospital. In our sample, which was from the 80s and the 90s and early 2000s, we did not came across transgender, but possibly it was not reported back then. So it's actually kind of a debate now in our hospital what we should have more knowledge about this group. So, but in this sample, no, we didn't find them.
And then there's another question about the victimization and treatment histories. Were they self-report or some collateral sources or reports reviewed as well?
Yeah, that's an important question. Usually what we had really big files because in the Netherlands, when people go to the TBS system, it's called ter beschikkingstelling, it's the mandatory treatment. There is a lot of information and a lot of collateral information about them from psychological reports, from the court, from police, from social workers, etc. So we have a lot of information. And if it was only self-reported, we didn't code it. So there had to be some evidence or some confirmation about the victimization, because what we actually also see sometimes in the female patients, maybe also in the male patients, is that they tend to exaggerate symptoms or maybe tell things that are not true. So we always looked for more information from social workers or psychologists. Yeah.
Another question about the FAM, whether you've investigated it in cases for like sexual violence risk. Have you looked at the FAM in sexual violence reoffending?
Yeah, that's also an interesting question, because I didn't tell that, but in our sample, we only had 10 cases of female sexual offenders. It was a very small group, and all of these female sexual offenders had a male accomplice, which doesn't mean that it wasn't serious, because it could be really serious, but it was usually not in sexually motivated. So we weren't able to specifically look at this small group because it's just a too small group. So we have considered of also looking at risk factors for female sexual offending, but it's really difficult because the literature is very scarce. So no, we didn't do that.
And then I think a couple people have questions about, and I don't know if you're going to cover this in your case study, so if that's so, then we can maybe skip these, but a couple people have asked about use of the PCLR with women, you know, using the PCLR or the SV, or, you know, if you do, what's your approach? So I'm not sure if that's something that's going to be in your case, or if that's something you want to answer now.
No, it's not in my case. It's also a complicated question, because we also did a study within this project into psychopathy. And what we did in the FAM is that we lowered the cutoff score for women to 23. And what we actually found was the prevalence rate was, when you look at the cutoff score of 23, instead of 30, it was about the same as with the men. But what you see in the female psychopaths is that it's more subtle behavior, more in a manipulative way. So there were some interesting differences, but also when we looked at the differences in offending, it seemed to disappear. So these psychopathic women look more like men. And what was also interesting in the follow-up study, it was a sort of, because the reviewers of the journal said, why don't you look at predictive validity of the tools for mortality? Because we found this high mortality rate. And we actually found some PCLR items to be protective for mortality. So protective factor, significant protective factor. So a little bit of psychopathic traits for women seem to be better for their physical health. So that's but what we do in daily practice is that we lowered the cutoff score, but we have to be very careful, because you don't want to put a label on someone as being psychopath, but we are really aware that female psychopaths do show more subtle behavior and less intimidating behavior.
I think we'll go ahead and do the rest of the presentation, and then we'll save all the rest of the questions for afterwards.
Okay, thank you. So I'm going to end with a case study, just to illustrate some of how, at least in the Netherlands, in our hospital, we work with these female patients. It is an actual case, but obviously due to privacy reasons, I changed some of the characteristics. This is a woman, she's 31 years old, a very intelligent woman. She went to university, but she couldn't finish it. And her history is that she grew up in a sort of a middle-class family, but there were some severe problems. When she was younger, the parents got a sort of violent relationship, violence both ways, and they divorced at the age of when Kelly was 9 years old. And both of them started new families, and this was really very difficult for Kelly, because she didn't feel she belonged with any of them, and they just started again, and she was on her own, she felt. So she started drinking alcohol to sedate herself at the age of 12, and she started to have sexual relationships with multiple boys, and she ended up working in prostitution. And she also encountered some sexual abuse in these circumstances. So what happened was, at one time she had a boyfriend, and she told him about her uncle. And this uncle had shown some inappropriate behavior towards her during her younger years, sexual. It was never proven that it was actual sexual abuse, but Kelly felt very uncomfortable with this guy, and she was really angry. And together they decided to kill this uncle. And they watched a lot of violent movies and also some gaming. And so they did, in a very violent way, they killed this uncle. So she was psychologically examined, and it was found that she had diminished responsibility for the offense because of severe mental disorder, borderline personality disorder, alcohol dependence. They were both very under influence when they committed the crime. She also shown self-injurious behavior. So it was considered that she was diminished responsible, and she got a combination of a prison sentence, but also mandatory treatment in a forensic psychiatric hospital. And the same was true for this boyfriend, but he went to another forensic psychiatric hospital. So when she came into treatment in the first years, what we saw, there were many incidents. She shown very sexually inappropriate behavior. She tended to flee into complex relationships with fellow patients, both male and female, sometimes at the same periods simultaneously. So there was always something happening around her. She had never been violent, but there was always some rush around her. So she was transferred to a more structured environment, to a ward with more structure. They invested largely in trauma treatment for her, and she got medication. And then she sort of stabilized her psychiatric condition. Psychotherapy focused on the development of coping skills. And she also did some program like creative arts, yoga, etc. And slowly she made progress. She became motivated. She demonstrated some self-insight, although she was not really able to handle according to the self-insight, but she knew what was happening. And there were less incidents, also less sexual relationships within the hospital, also because of the structured environment. So after about 3 years of treatment, she started in the resocialization phase, and that means that she's going to live outside of the hospital, but under intensive supervision of the hospital treatment team. So they visit her and they help her with all kinds of practical things, and she still had some psychotherapy in the hospital. However, when she lived on her own with the supervision, but still she lived on her own, she encountered loneliness, and she started to flee again into alcohol abuse, and also started visiting bars and get into sexual relationships again. So it was considered that it was not safe for her, and it was too risky for her to live on her own. So she was readmitted again to the hospital. And then during that period, she felt sort of relieved to be back in the hospital. But what we also noticed was that she became very dependent upon her treatment staff, upon her psychotherapist, for instance. But still she made some progress, and she did not show relapse into alcohol. She did not show relapse into incidents within the hospital, no violence at all. So again, she started with the resocialization phase. And I'm going to show you the risk assessment results, and these are based on the last 6 months with this intensive supervision. She had work in which she felt really valued. She had good contact with the supervisors, no relapse into alcohol. Her finances were in order, but there was still some issues with intimate relationship because she wasn't always honest about it to her supervisors. So I'm going to show you, and I see that I have only a couple of minutes left, so I will speed up. These are the historical items for Kelly, and as you can see, the red colored items are the items that were present, and especially relationships, substance abuse, and personality disorder were deemed important historical risk factors for Kelly that we should really be aware of still. In the clinical items, we see some progress. We see some more self-insight, although it's not optimal yet. But we also see that the risk factor instability is still present and still an important risk factor for her. And when you look at the risk management items, also some progress, some positive development, but we also saw that stress and coping was still an important issue for her. It was really difficult for her to cope with her problems. Then we coded the FAM in addition to the HCR20, and we saw some additional items that were deemed important also for the risk management. We saw this suicidal behavior, self-harm, to be important because this was really a sort of way of coping with her problems, to hurt herself. And we also saw some manipulative behavior, although it had been going down, but still we saw some manipulative behavior, especially in her dependency from the hospital, because she threatened, if you let me go, then you will see what happened. And it was sort of manipulative. We also noticed that problematic intimate relationships would be an important risk factor for the future because she tended to flee into new relationships. We also coded the SAPRO for protective factors. And what we saw actually here is that Kelly had quite a lot of protective factors. She was intelligent, which made it more easy to explain risk assessment results to her, but also to make progress, to find a job, etc. It made it easier. She also had work, which was very important to her. She was motivated for treatment. She had some goals for life, and professional care was deemed as a really important protective factor. So the fact that she still was being supervised and especially being helped by her treatment staff. So these are the keys, the most important protective factors, but she also had some goals to work on to further improve her coping, which was a problem, also self-control, and social network was seemed important for her to further develop that. So overall, what we saw was that she had many historical risk factors, and instability and stress still relevant dynamic risk factors, and the FAM showed some additional risk factors, but also multiple protective factors. So overall, the conclusion was that in this context, with still the mandatory treatment and intensive supervision, that the risk of violence to others was considered low for the next year, but the risk of self-destructive behavior was seen as moderate to high. And it was concluded that continued treatment and supervision would still be needed. We also tried to make a risk formulation because some of the risk factors are really interrelated, and we believe that it all started with these problems during childhood, traumatic experiences, the development of a borderline personality disorder, low self-esteem, and as a way of coping, she started to abuse substances. This was also a disinhibitor. The relationships caused all kinds of problems. And all these risk factors together, they could cause aggression, but also self-destructive behavior and also sexual risky behavior. So the risk management strategies that were considered for the most relevant risk factors is to further still develop the coping skills, work on the self-esteem, help and guide her with relationships. So she still had ongoing psychotherapy, medication, and we deemed it very important to have a very gradual discharge planning from the hospital. So we work closely with the probation services, but also with some outpatient mental health services in order to further build up the protective factors. And I see that it is time now, so I think I have to go very quickly.
I'm going to jump in real quick. I just want to let everybody know that the link for the CEU survey has been posted. If you have to jump off now, you're welcome to. We did do some questions, so I'm going to give Vivienne a little bit more time to finish up before we start questions again. Thanks.
Okay, so these are actually my last slides. More generally about gender responsive treatment. This is what we saw in the case of Kelly, but more generally in the treatment, I think that trauma is really important, and it's not that it's not important for the male patients, but it should be approached in a different way. There are some good suggestions in the literature about that in what the differences are, but also parenting is an important topic, not for Kelly, but for other women who are mothers. To become financially independent is an important topic. But we should also be very aware of the risk of re-victimization, especially in mixed settings. In the Netherlands, the settings are all mixed, so men and women are residing on the same wards. So this is actually a very dynamic environment, and relationships start, and we really have to supervise that very closely and be aware of the risk of re-victimization. So frequently conduct risk assessment also for partner violence. And we should also have clear policies, what to do with, for instance, intimate relationships. Another topic, and I don't have much time to go into that, but what I see in daily practice is that it can be quite of a burden to work with female patients because the high prevalence of borderline personality rate, it's sometimes very difficult to work with these women. So it's important for staff that they are being acknowledged in that and they get sufficient supervision and coaching. And obviously, like I said earlier, collaboration with the general psychiatry is very important because we saw that most of these women had been in treatment before in general psychiatry. So there may be some opportunities to have better collaboration and possibly prevent serious offenses from happening. So the overall conclusions, the female forensic psychiatric patients is a highly traumatized group with some complex psychopathology. It's not easy to treat them. And I think it's important overall that we acknowledge that there are some gender specific aspects and to be able to discuss about it and to think about more gender responsive treatment strategies. But definitely we need more research. This is always the case with research. For instance, on the impact on staff, the impact on the children. And we also definitely need more research in larger sample and with multiple outcome measures to validate the risk assessment tools or the PCLR in female populations. So that brings me to the end of my presentation, and I'm sorry I'm a bit late, but I want to thank you for your attention. And if there are any more questions, please hang in there and let me know.
Thank you so much, Jan. We've also been getting comments just saying wonderful presentation, really interesting information. We could all listen to you for hours. But we do have some questions for those of you that have some time just to hang out and do questions. Vivienne's already graciously offered to stay on for a few more minutes. So we're gonna work through some of those now. So there's two questions kind of asking about maybe the nature of the forensic sample versus perhaps a prison sample. Do you think that your risk assessment results might be different, if at all, if you studied women in prisons? And then a somewhat related question to that is, have you tried validating the instrument, the FAM, in US populations? So kind of a two-part question, I guess, but mostly, I guess, about the sample and if you think the results will be different with prison population. And then also, has there been any work done looking at, a larger, because there's some folks commenting about the fact that maybe the results could be because of your small sample size, and then also, the forensic instead of a prison sample.
Certainly, and I would be thrilled to collaborate with prison researchers, because in the Netherlands we have tried it, but it didn't actually, and actually now during the corona pandemic, it's really difficult to gain access to the files. But I think a larger sample and from more correctional facilities would definitely be very helpful. We haven't tried that yet, but I hope to do so in the future. And with respect to other countries, I know there has been a study in Canada by Duncan Greek. And I know there has been a small study in New York, and sorry, I forgot her name, but I can look it up. So also small studies. So we really need bigger samples to show. Yeah, definitely.
Yeah, for those of you that do research in this area, you know that that's a common problem. We can never
Yeah.
of a
Yeah.
sample size with this population. So the next question is, are there any differences in reliability of the final risk judgments for men versus women? Did you guys look at that difference?
No, we looked at that, and also in previous studies we did not find it. So it was the inter-rater reliability was okay for both. Yeah.
And then somebody just has a comment about the high percentage of borderline personality disorder diagnosis, and sort of reflecting on perhaps the high rate of trauma being related to that diagnosis, and like instead of a borderline personality diagnosis, it being more of a reaction to severe trauma. And I guess just wondering what your thoughts are on that in your sample, because I know we see that quite often in our samples here in the US.
Yeah, that's a good question, because what was notable is that we found a low prevalence rate of post-traumatic stress disorder. And I actually, when looking at the victimization rates, I assumed that would be higher, but I think that's probably being missed in diagnosing these offenders. So there really may be a bias in the diagnostic processes. I think so. And in our own hospital, when the patients enter our hospital, we have this complete diagnostic procedure, but they're mainly being examined for personality disorders or schizophrenia, but not for post-traumatic stress disorder. So I think there's underreporting there.
And then there's one question asking about whether religion plays an impact in your study. And I know that the STAPROF doesn't necessarily have religion as an item, but it's sometimes coded as like a motivating or, one of those factors. So there's a question about that. And so I don't know if that could be.
And as a risk factor or a protective factor?
The person doesn't clarify. They just said, did religion play an impact in your study?
Well, there is one case I remember that was a woman who was really religious, but she used it as an excuse for offending because it was a sort of very strange religion, and there were some sexual activities involved in this religion. So she had it as a sort of excuse for offending. But, well, what we found actually in protective literature is that religion can be a protective factor, especially for girls. But this is also, there are only a few studies into that. Yeah.
The next question is if you think, at least clinically, you see value in using the FAM with men, especially around the issue of victimization, possibly in the sex trade.
So to use the FAM for male patients, that's the question.
Yeah.
Well, actually, when we
focus on sex trade worker, like male sex trade workers, because there's some items on there that could potentially be relevant for men in that population.
That really could be the case. And when we were developing the FAM, sometimes we said to ourselves, maybe we are just improving the HCR20 version 2, because some of the items were also seemed important for the men. And actually, there's also what I get back from hospital staff is also the items relating to children, that it can also be very important for fathers. But what we saw in our study is that the children of fathers were more often out of the picture. So these children were living with family, or we had not sight of them. So there may be a difference in there as well, but that can also be an important factor for men as well, as it is with the victimization. Yes, true.
Yeah, and I know that that's some feedback that we've gotten a lot with Duncan and like when we presented stuff, people often say like, well, these could be also relevant for men. So it's I think, an interesting question for future research for sure. Somebody was asking a follow-up question on the PCL cutoff scores, and they're asking if you would recommend using the lower cutoff for women as a standard of practice, given the differences, or what are your thoughts on that?
Well, I think you have to be really careful what the aim is of the assessment, because when you use it for to be used in court, you have to be really, really careful. But when you use it for clinical purposes, it may be useful. This is at least how we do it in the Netherlands. So we do not report it to court, but we use it in the hospital, because sometimes these female psychopaths are, we are really aware of the male psychopaths. We are a bit afraid of them. They're intimidating. They tend to have longer treatment admittance, but in the female cases, they tend to have lower duration of treatment. So it seems that we are not, we do not see them in a proper way because it's so subtle. So for clinical purposes, I think it's useful, but I would really be very careful if using it in court, because it has to be validated further. Yeah.
And then the question that we did earlier that was a little unclear, that individual did clarify a little bit and said that what transpires in prison affect media portrayals of female, action heroes or violent women? Like, do we think that, or do, so that's the additional question to that, is like, do we think that prison, like what happens in female prison, affects the media portrayals of females?
And what actually happens, I'm not sure if it's maybe a cultural thing, that it should be, well, I think there would be an effect, but I'm not sure how. And I think in the Netherlands, what you see is when females are portrayed in the media, it's either, or they are sort of like a witch, a very bad, evil person, or they're very, well, like more the victim. So it doesn't seem to be a nuanced picture. It's either that way or that way. Maybe that's
kind of the Madonna whore, the
yeah,
right.
yeah.
Does histrionic PD features present with female sexual offenders, or is it mostly ASPD and BPD? So did you see histrionic features in the female, I guess, sexual offenders, but maybe also just in general in your sample?
Well, what we saw in the female sexual offenders, so only 10 again, but we found some dependent personality disorder. I don't think it exists any longer, but what was diagnosed, but also quite a few with antisocial personality disorder. And they also had shown some other offenses. So it's not only typical sexual offending, but multiple offending. But mostly personality disorder. But this can also be a very typical Dutch finding, because in the Netherlands, in the forensic mental health care, we have a large sample of personality disordered offenders. And I think that the more XS1, maybe they more often go to general psychiatry.
And then another question says, if possible, could you speak how the principles of gender responsive treatment could be beneficial as applied to male clients? So they do say if possible. So so they're asking about how gender responsive treatment could be beneficial as applied to male clients. This is the question.
How it could be beneficial? Well, we have to do some research on that, but I think it's important to be aware of the differences, and to what is especially important is trauma, and the trauma, again, it's also important for men, but it should be approached in a different way. So for women, it's more important to learn to set boundaries, to be to have more self-esteem, to be independent. And for the male patients, it seemed to be more important to have social skills and emotion regulation. So there seemed to be a different approach in how to treat the trauma. So I think that could be beneficial of gender responsive treatment, and also to train staff better in treating female patients, because it demands some specific skills from treatment staff.
And then I think we'll just do one or two more questions. We're almost out of questions anyways. Lots of great presentation, great information. Thank you very much. So lots of comments coming in like that. I guess just one question says, since risk assessments can be so harmful to incarcerated people in the United States, for example, longer sentences, refused delay parole dates, and etc., and they have such low validity rate for violent acts, should we be pushing for their eradication? So it's kind of a loaded question, but I think an interesting one. So what are your thoughts about that? And I know you're coming from a different system in a different country, so it'd be interesting to hear your thoughts.
Yeah, I think in general you have to be really, really careful because there are high stakes for these persons. So you should really, really be very careful and certainly modest also about it, because these tools are developed as a sort of guides to help us, but it's not like rocket science or something. You have to be really, really careful. And this is at least what we try in the Netherlands, to always be descriptive and to explain to the court and not just provide numbers or something. So, well, yeah, being very careful and modest, especially with the female offenders.
All right, well, thank you so much. This was great. Everybody really enjoyed it. Thank you so much for giving us your time. We really appreciate it. And I hope you have a wonderful rest of your day. Is it starting? You have a
In the Netherlands,
ending your day or starting your day?
Evening, yeah.
All right, well, we're going to stay on just a couple minutes for folks to get a chance to grab the CEU link. We'll just hang on for a couple more minutes, but everyone else is welcome to jump off. And thank you again, Vivienne. I appreciate it.
Okay, you're welcome. Thank you. Bye-bye.
Bye.